Okay, we're going to start. Good day, everyone around the world. My name is Jorge G. Ruiz, and I am a geriatrician, investigator, and associate director for clinical innovation at the Miami VA Medical Center, GRECC, Geriatric Research Education and Clinical Center at the University of Miami in the United States. On behalf of the organizing Frailty Seminar Series Committee and the Global Frailty Network, we welcome you all to our monthly Frailty Seminar Series. Before I introduce our panelists, first I want to remind you about some housekeeping issues. Remind you that when you want to ask a question, please use the Q&A feature in the lower part of your Zoom screen. Try to avoid the chat feature unless you want to communicate to our colleagues or to us about any technical issues or otherwise. I want to remind you about the importance of the evaluations that you will be receiving at the end of the webinar as a link or as an email. Remind you about the purpose of the Global Frailty Network, that is to exchange and share evidence-based practices and research advances about all aspects of frailty. All healthcare professionals and researchers, policy experts, trainees, and organizations are welcome to join the network. Now, I will introduce our panelists. It's my privilege to introduce this distinguished group of speakers, experts in the field of frailty and cognitive impairment for our webinar today. So I will make the introductions brief so we have more time to enjoy the presentations and also have time for discussion and answers, questions and answers from the audience. So I'm going to introduce our speakers in the order that they'll be presenting first. And the first one is Dr. Kenneth Rockwood. He's a professor of medicine, geriatric medicine and neurology, and the Catherine Allen Weldon Professor of Alzheimer's Research at Dalhousie University in Halifax, Canada. He's a leading authority on frailty and certainly cognitive impairment. He has key roles on numerous studies in Canada and elsewhere. Dr. Rockwood received his medical degree from Memorial University in St. John's and completed training in internal medicine at the University of Alberta and in geriatric medicine from Dalhousie University, again in Halifax, Canada. Our second panelist is Dr. Carlos Alberto Cano-Gutierrez. He's a physician from the Pontificia Universidad Javeriana in Bogota, Colombia, and he's also a geriatric medicine physician. He's currently a full professor and former director of the Institute of Aging of the Pontificia Universidad Javeriana, as well as head of the geriatric service at the San Ignacio University Hospital in the city of Bogota. He's a senior researcher at MinCiencias, that is part of the Colombian government. He's also the past president of the Executive Committee of the Latin American Academy of Medicine for the Elderly, ALMA. And the last panelist, unfortunately, he will not be able to join us live, but we'll have a recording and he may be able to answer questions after the webinar. Is Dr. Bruno Vellas, who is chair of the Toulouse Gerontopole in France, head of the Department of Geriatric and Internal Medicine and professor of internal medicine and geriatrics at Toulouse University, France. He's director of the World Health Organization Collaborating Center for Frailty, Clinical Research and Geriatric Training, member of the INSARM unit team on aging at Toulouse, and an adjunct professor at the Department of Internal Medicine, School of Medicine, and the University of New Mexico, Albuquerque, New Mexico, United States.
Well, sometimes perfection has to do. Thank you. I begin with a land acknowledgement, which is to say that I'm speaking to you from Mi'kma'ki, the ancestral land on ceded territory of the Mi'kmaq people. So today I'm very keen to speak about frailty and cognition. I have some disclosures. They're not particularly relevant for here. I won't talk to anyone about it afterwards. I'm going to skip over in the interest of time. So let's start with this. We'll talk about frailty first, then we'll talk about cognition and the intersection. So what I bring to the table for a lot of this is the view that frailty is a graded state and reflects deficit accumulation across the life course. So here we see on the x-axis age and on the y-axis the degree of frailty. and the black line is the mean degree of frailty at any age. And you can see that the mean degree of frailty at any age increases. So the older you are, the more likely you are to have things wrong with you. But what's really cool is that the variability in this increases as well. And that's really what frailty is, variability in the risk of an adverse outcome for people with the same degree of exposure. And here, variability in the risk of death for people the same age. And what we see is that the degree of frailty helps to explain very much why individual people die. But what this means is that the rate of deficit accumulation on average is about 4.5% per year, and that translates into a doubling time of every 15 years. And so what we see here is how these doubling times work. So when someone's 15 years old, they've got almost nothing wrong with them. You double that at 30, it's still almost nothing wrong. It's just like compound interest. It's not the first doubling time that's important, it's the last one. Though theoretically there is a doubling time between 90 and 105, for most people, the burden of mortality is such that most people, in Canada at least, this is the last of the doubling times that they will have, is here between the ages of 75 and 90. And age 75, therefore, turns out to be really important because it heralds this rapid increase we see in the incidence of many illnesses of old age. So this is hip fracture, for example. So age on the x-axis, incidence per 100,000 on the y. You can see 75 is really where things take off. But importantly for the discussion today, it's where the risk of frailty, and again, I'm using Canadian data, the risk of dementia really begins to accelerate. And the claim from Frailty is that this is not by coincidence. As we know, part of our creed is the problems of old age come as a package. And what we're seeing with dementia should not be different. So it's important that we don't equate dementia with Alzheimer's disease, or certainly late life dementia with Alzheimer's disease. And something else that we see that happens in old age and really should persuade us of the invidiousness of imagining that all of dementia is Alzheimer's disease is this. So here we see from the Rush data, expression of human cortical proteins in relation to various types of pathology, microinfarcts, macroscopic infarcts, hippocampal sclerosis, and so on. But I draw your attention down here, Alzheimer's disease and Alzheimer's dementia, to a series of important human cortical proteins involved with dementia. And you can see that the colors all don't line up. So this is a heat map of the extent of the expression. And Alzheimer's disease is not the same as Alzheimer's dementia. And Alzheimer's dementia is the thing we need to explain. So how should we think about that? So again, from our standpoint, frailty happens across the life course. Crucially, there are grades of frailty. And interestingly, from a clinical standpoint, is that the stereotypical clinical manifestations arise as the degree of frailty increases. So here we see a bunch of people all age roughly 85. And this is a man, he's out running. This part of his run, you can see it's not a really big stride length. He doesn't have good heel, kick, and such, but he's running and he's 85. And his degree of frailty is very low. He's quite fit. This is someone who's very mildly frail. And this person is just beginning to express some of the important things that happen with people as they get older, and as their ability to provide these highly integrated functions like mobility and balance and function and cognition and social engagement and so on, that begins to decline. And this person is very severely frail, and in fact, towards the end of life. But the point is that this person, each meet criteria for being frail. So it's crucial that we understand degrees of frailty, because they obviously will have different healthcare needs. So what has been really enlightening and useful, and I think is the basis of why I feel about frailty and dementia, frailty and cognition the way that I do, is a bunch of work that really began to accelerate with this from Lindsay Wallace, then a PhD student, now a postdoc at Cambridge, who when we worked together, worked with the Rush data, and what you see here now is on the x-axis is the degree of Alzheimer pathology, just the plaques and tangles and such. And on the y-axis is the probability of getting Alzheimer's dementia. And these three lines represent grades of frailty, the least amount of frailty and the most amount of frailty. So you can see here that your people are least likely to have dementia if they have a low degree of frailty and no Alzheimer pathology. But look here are people with very little Alzheimer pathology, and yet just over half of them with the lowest degree of Alzheimer pathology have dementia when the degree of frailty is high. Now, as we come to this part of the curve, we can see clearly that if you've got a lot of Alzheimer pathology, dementia becomes pragmatically irresistible. But most people find themselves in these parts of the curves here with a degree of Alzheimer pathology that seems to be resistible to some important extent. So that led us in this review in 2021 to make this statement. Frailty is not a disease, but it profoundly influences disease expression. And it influences it in predictable ways that make it complicated to imagine that we should look at people as though they just have one thing wrong with them. Still, it remains the case that those who are at the lowest dementia risk have a healthy brain and a healthy body. And those at the highest dementia risk have unhealthy brain with a lot of various types of neuropathology and are not that fit. But here's the interesting point that many people have been able to demonstrate. Exercise and whatnot is good for you. It is a way to tolerate or make tolerable a degree of neuropathology to which other people would succumb with respect to dementia. So that's at the stage of death and when the autopsy is done and such. There's information that's useful prior to that. So these are data from the UK Biobank done with another brilliant postdoc who worked with us, who's in Queensland now, David Ward. And here is the result of how the incidence of dementia played out in UK Biobank. Here's the hazard rate for incident dementia by low degree of frailty, intermediate, and high, also stratified by polygenic risk. So a low degree of polygenic risk and no frailty was the reference. You can see that even with people with a low degree of frailty, having high polygenic risk increases the risk of dementia they have. But you can also see that that risk of dementia remains less than people with low polygenic risk and a high degree of frailty. And in fact, the way it plays out is that if we consider here the risk of developing dementia in relation to polygenic risk, this is the risk for each 1 standard deviation increase in polygenic risk. And it's not what the driver of dementia is in these people with a high degree of frailty. That's not a significant source of variation, at least more absent in men than in women. But another important piece of the puzzle as we begin to think about this, Matteo Cesare and Marco Canavelli have done much the same with respect to biomarkers in the ADNI database. But here's something that I find very intriguing, which is this. Frailty mediates the risk that's conferred by unhealthy lifestyle behaviors. So here is the decline in risk, a decline in the frailty index in association with an increase in the number of healthy lifestyle behaviors. So again, helping us to start to understand where this might lie, appreciating it's not a randomized controlled trial. And then I come back to the work from Rush, commenting on this part of the result, which is that cortical proteins implicated in Alzheimer's disease do not necessarily work through Alzheimer dementia, don't necessarily work through Alzheimer's disease pathogenesis. And instead, non-AD neurodegenerative and vascular diseases and other pathways are at play. And indeed, some proteins are pleiotropic. So lots of things to think about and get to grips with over and above the usual story of how this works. So that's what leads me to this conclusion, is that we have to stop equating late life dementia with Alzheimer's disease. We should see it instead as an age-related, multiply determined, inherently complex. In other words, it's a frailty syndrome. And such a stance, I think, would be better for public policy and for clinical care. That's an assertion. But the point I'm trying to argue here is that it will likely yield better science, and from that, more realizable treatment and prevention. I just want to acknowledge that I worked with a large number of people on this over the years, been funded by a great number of sources, and I thank all of them for their help and inspiration, and I thank you for listening. And
Thank you,
now let me
Dr. Rowan.
stop sharing.
We'll have the questions at the end. And now, Dr. Cano, please upload your slides.
Thank you. Can you see the presentation now?
Yes, it's fine.
Okay, thank you, Dr. Ruiz. Thank you for your invitation to this webinar. And also, speak after Dr. Rockwood is very important. It's a good opportunity to express the idea, the concepts related with these two important topics, the frailty and the cognitive impairment. I am working in Javeriana University. You presented me that, thank you. But it's a private university. We have more than 25,000 students in our university. That's in the center of the city. And also include medicine with more than 1,000 students in undergraduate and in postgraduate, 700 students. 30 in geriatric medicine for 4 years of training. And in the north of the city, we have a new center. It's a building related with Intellectus, is the name for Memory and Cognition Center. And we start this project 12 years ago. When we are speaking about the frailty and the cognition, maybe you have the temptation to include both in one concept, and I am going to try to explain that, but maybe is a controversial topic, and I understand that. I starting with this paper we published 12 years ago. And in this study, we was studying in the older Mexican American, that's Mexican people living in US. The name of this study is IPC. And we was working about the concept of the relationship between frailty and cognitive impairment. And in this case, the prediction of mortality. This is a study with different waves. And that is usual, and we know that after 5 waves, the mean mental state examination decline of the population and the average of the mean of percent of frailty increase, and that is the usual possibilities when you are studying in a longitudinal study. That is a good example. But the most important of this paper was the relation between survival and frailty and cognition. And in this case, the people with a better survival in this study after 10 years was the people with non-frailty and high cognition. And the people with the bad results were the people who had a frail and low cognition. And we starting the concept and the idea and to understand if these topics are different or have a connection between the concept. And in this systematic review and meta-analysis published 6 months ago, they conclude that the mean mental in the score is significantly more lower in frail compared with robust people, and the same if we compare pre-frail and robust person with the Linda-Free criteria, that the phenotype criteria. And for that is the summary of the idea and the results that we was working 12 years ago. And for that, the frailty, we have many approaches. We have for example, the possibility to understand the frailty in one part of cognition, but also in social, in nutrition, and in physical approach. In this case, I am going to speak about the cognitive approach. And for that, I am going to have a small summary related with the concept. In 2001, the first concept and idea was related with the clock test study and the risk of protector to Alzheimer's disease. That is the starting with the idea, but in 2006, Panza et al., they studied the vascular risk factor related with dementia. But in 2013, the consensus about International Association of Geriatrics and Gerontology, they have a proposed criteria to cognitive frailty definition. That is a new syndrome. At that moment, we was working before about the idea, but after 2013, we have the criteria for cognitive frailty definition proposal. And in 2018, we have the last change in criteria related with this syndrome. This is a review with our team related with frailty cognitive syndrome and the evaluation for that. And in summary, we can compare, sorry, are in Spanish, but the concept is the comparison between the criteria in 2013 in both between 2018, the new criteria, and in both cases the first condition is the possibility, or you need the frailty physical diagnosis with the criteria, that different options, but normally with the phenotype, and also we can have other possibilities to the diagnosis. And the second, in the 2013, the CDR was 0.5, but in the new criteria, they proposed the 1.5 standard deviation to the cognitive functions. But the last condition is that in both cases, you need to exclude the dementia and other Alzheimer's disease on other dementias. And in the new criteria, they propose the no dependence in activities of daily living. And for that is the criteria that we are working now. And for that, in summary, we can say the criteria for cognitive frailty, I say it's a proposal concept, and is this syndrome in older adults, is the evidence of physical frailty and cognitive impairment, but no clinical diagnosis of Alzheimer's disease on other dementia. And we have a study relating with this concept. And in Colombia, we have a cross-sectional study that is SABE to elderly people with more than 24,000 elderly people in all country. And you have a exercise to understand the prevalence of cognitive frailty, and in this study it was 10.4. In the last slides, I am going to speak about the possible mechanism that relate with the physical frailty with cognitive decline. In this paper, we have a very new good review related with the possibilities that speaking about the chronic inflammation, for example, of the biomarkers to dementia and other biomarkers related with cognition, and also with oxidative stress, etc. But in summary, we can say that the cognitive frailty mechanisms are related with the both frailty and cognitive in the same way, and in two cases, and we know the results of the previous presentation related with the neurotoxic accumulation of beta amyloid in the brain of the people with the both situations. The lifestyle and mental health also is important, and cardiovascular risk factor is relational with both, and also the alteration of the endothelial system. And in neuropathological also we have other things relating with both, but nutritional inflammation and other metabolic and important ways relating with the both are common in the two diseases. And finally, and with this, I am near to finish. The message to keep in mind is that we have a very clear association between frailty and cognitive decline. That is common. We have a common mechanism and include vascular factors, hormonal change, nutritional inflammation, etc. And that is in the moment is clear. I understand the cognitive frailty is a concept under construction. We need more evidence related with the newest longitudinal studies and to know and to identify common ways and mechanisms relating with the older to appropriate target treatment options to the both problems. And I think it's important to continue the studies relating with this topic, because we can have new possibilities to have a healthy aging in this aging phenomenon that we have now in all the world. That is my team. We have in our team 20 geriatricians and 30 residents. And thank you for your invitation and your attention. I am ready to the questions. Thank you.
Thank you. I am very happy to present some update on to what we got recently on cognitive frailty. As you know, we start working on the concept of cognitive frailty with this first paper that was published in the GNHA in 2013 about the subject that have both cognitive decline and physical frailty. After that, in a few years later, we have worked on the New Mexico aging process study on a longitudinal study, 9 years, of almost 600 older adults. And as you can see here, for 1 year, for example, we have 7% of the subjects that start to have some slow walking speed, and 6% that start to have low MMSE, and 1% that lose both on memory and physical frailty. And when we look at recovery, we found that 50% of the people that have some decrease of gait speed recover the year after. We have 64% for cognition, but for those that have both cognitive decline and physical frailty, we have only 20% that are able to recover. And if we look at those after 75 and 78, you can see that we have twice more people that have a decline on mobility, some more on cognition, and 6 times more on both cognition and mobility. For that, in the oldest old, cognitive frailty appears to be very common. And as you can see here, the possibility of recovery is really low. And that was some interesting data that we got. And from this data, we can see that so the subjects that have cognitive frailty are very less likely to recover. Now we got some data from the COG-FRAIL cohort. The COG-FRAIL cohort is a cohort of 317 cognitive frail older people to better understand what is cognitive frailty. You can see here the mean age is 83. near 40% of these people live alone. They have mostly poor education level, and they have many comorbidity and drug consumption. If we look deeper, you can see they have MMSE around 24. They are not demented. They still have some good autonomy. They lose some instrumental activity daily living. 54% are pre-frail, 45% are frail. And concerning the criteria of frailty, 15% have weight loss, 45% exhaustion, 80% grip strength low, 31% low speed walk, and the majority have sedentarity, 72%. And when we look at PET amyloid, we found that 54% of the subjects are amyloid PET positive, and we need to better understand what that means. We have also some data, some new data from ICOPE. You know, ICOPE is some integrative care for older persons that is recommended by the WHO. And on the step 1 of ICOPE, we have on the screening tool some item to measure cognitive decline with spaced time orientation and also 3-word recall. And we have some item to look at mobility with a 5-share rise test. And also we have the other item on nutrition, visual impairment, hearing loss, and mood and depressive symptoms. And the interest of ICOPE is that we monitor this function. The subject can do by themselves, self-assessment with apps or with a chat box, or they can do it with a healthcare professional. All of the data are going on the secure database, and we follow this subject. As you can see here, the nurse can see if some people have some new abnormality on cognition, or if they have some new also on locomotion and other items to intervene as soon as possible. And what we found in about 32,000 subjects that we follow now with the monitor, that the mean age is 74, that 40% have some cognitive complaints or cognitive decline, 32% have some abnormality at the CRS test. We found that 38% have some depressive symptoms, 28% some hearing worsening, 22.7% some vision worsening, and 12% have some recent weight loss. And more deeply, we found that 23% of the population are both cognitive and physical frailty. That means that the prevalence of cognitive frailty in this population is large, 23% of the population. And as you can see here, we found really one integration between all of these items and functions. For example, those that are mobility, cognitive complaints or disorders are more likely to have a locomotive problem, to have nutritional disorders with weight loss, to have symptomatic symptom of depression, or to have hearing or vision loss. And this is transversal, but also on predictive. Those that have cognitive decline are more likely to have in the future more locomotion decline. And what is really important with ICOPE is that we are able to maintain intrinsic capacity function to monitor and maintain the intrinsic capacity one by one. The problem is if we wait too much in the frail people, they lose already 3, 4, 5 intrinsic capacity, and it's more complicated to recover. But if we do ICOPE, we can find one by one when they lose some function, and that can help us in the future to prevent cognitive frailty. And we really need to prevent cognitive frailty because it's difficult to recover after in the people that have both cognitive and physical frailty. And to conclude, I would like to say that we hope to have in the future some new hope with neuroscience, because aging is a major risk factor for cognitive frailty. It was considered as not modelable, but recent research shows that it's probably possible. We need to be able to measure biological age and not only chronological age. And we will have some probably new targets that can bring some new therapy in the future. Thank you very much for this symposium on and web seminar on cognitive frailty. That is really, as you can see, one important topic. Near 23% of the 32,000 people that we follow with ICOPE have cognitive frailty. Thank you very much.
And okay, so let me start with some of the questions here. Many researchers regard frailty as it affects the physical health domain. However, recent publications argue that frailty should be seen not only from the physical health domain, but also from the multifactorial perspective. How do you, I guess is the question is, what's your take on that in relation to cognition and the intersection of cognition and frailty, so-called cognitive frailty? Dr. Rockwood, I'm not sure if you are. Or Dr. Cano, if you want to answer that question.
Yes, I think, no, maybe the Professor Road is going to answer
please.
first. Okay, go ahead, please.
Sorry, I was just trying to get, I put an answer in the chat, but I think I may have misplaced the answer to the question. As I was busy doing that, I missed this question. So you go ahead and I'll listen.
Dr. Cano?
Yes.
Hello, can you hear me?
Yes, we
Yes.
can hear you.
Okay, fine. Yeah, so regarding cognitive frailty, I think the point has been made it still needs some work in terms of the development. The issue that I have with it is this: the genius of the physical frailty phenotype, right, with the 5 items, cognition was not one of them, and yet it picks up a large amount of cognitive impairment. So what does that tell us? It tells us that everything's hooked up, particularly in the brain. And so for me, when I'm in clinic looking at patients who have dementia, I'm very fortunate. I work with with a great team, and they do a lot of the cognitive testing and such. But the thing that I spend time on is the motor exam, because there's aspects of the motor exam that change that help me understand whether there is disease progression that we might or might not be picking up in respect of what the cognitive tests show. So I have no objection at all to the notion that the body and the brain are hooked up. I think cognitive frailty is at once too broad and too narrow. You don't need to invoke cognition, talk about cognition in a physically frail person. It becomes an attribute. And if we are looking at things that are all hooked up, then why restrict it to 6 items? So that would be my general take on cognitive frailty. Certainly from, as a geriatrician, we wind up doing the bulk of a comprehensive geriatric assessment on everyone we see. We have tons of information. Why throw a bunch of it out based on theory? And why not just let the data organize and speak for themselves, which is what my claim about the frailty index approach, deficit accumulation approach would be. So that's my general sense of the lay of the land. But the most important thing is that we pay attention to cognitive impairment in old age as reflecting an entire person with an entire set of things wrong with them, and that we develop science that would look at that. And my concern with where we are with science right now is we're still talking about Alzheimer's disease in late life, but we don't enroll those people in the trials, and we seem to turn our back on the findings which show that most people with dementia have much more than Alzheimer's, even the ones who have a clinical diagnosis of Alzheimer's. So my concern is we need to be sure that the concepts that we're working with are going to inform the science and inform the clinical care.
Okay, Dr. Cano, anything to add? Go ahead.
Yes, thank you. I think that when we was starting the criteria for the Linda-Fried criteria more than 20 years ago, the principal characteristic for the phenotypes were the physical approach. Yes, not cognitive, no other approaches. And after that, when we have the Cano-Gutierrez index, they include, your group include the cognitive and other possibilities. Is a big examination, is very generous in the criteria, but the cognitive is part of that. And after that, we know that the activities of daily living and the physical activities, that's included in both in phenotypes and index, are very important. And the question is the relationship between physical activities and cognition. For example, for diagnosis, for prevention, for early diagnosis, for example, the walk, the speed walk, and other scales relating with that, and also for intervention, for treatment, for the dual tasks, for example, the intervention in cognitive and functional training. And I think the most important way to research now is to understand what is the real relationship and the possibilities to have a good intervention. And I think it's possible to have, especially in epigenetic and the other treatment approaches, to prevent and to intervention in the risk factor to frailty and cognition decline. And I think that we need more information, but I think the way is that to understand better the relationship between the two concepts.
Thank you, Dr. Cano. And there are some questions that are related here. I think you can see them in the Q&A. I guess the question is, does that mean that everyone could get late life dementia related to age, but not everyone can get Alzheimer's dementia? I guess, Dr. Rockwood, you, I think, addressed that issue.
Yeah, so again, I want to make this point. What we call Alzheimer's dementia has a very particular history associated with it, right? It used to be said that we could only definitively diagnose Alzheimer's disease at autopsy. That's the McCann criteria from 1984. And in those days, the notion was the best you could do clinically was a possible or a probable cause. And we had in our mind that Alzheimer's disease was the gold standard for, neuropathology was the gold standard for an Alzheimer's diagnosis or any neurological diagnosis. Two things wrong with that. Number one is that gold standard is a flawed concept in economics. Why we would import such a poor concept and put it up on a pedestal, beyond me. And I can speak to that more if anyone wishes. But as soon as the community-based autopsy studies began to come out, we saw that was not true. It was spectacularly not true. There was a big mismatch between who had Alzheimer's disease, which in those days required dementia to make the diagnosis. There's a big discrepancy between who had Alzheimer's disease under the microscope and who had it in real life. And it took the field 15 years to get over the fights where people say, oh, no, like if you'd used my test, they would have shown they had dementia. It was mismatch. It was not the right criteria were used, and so on and so on. But as the data became too big for that to bear, then there was a mismatch, which largely has not gone addressed. So then people said, oh, I know what to do now. We'll say there's Alzheimer's disease and there's Alzheimer's dementia. And the Alzheimer's disease, when you got the biomarker, and boy, if we work really hard, maybe we can prevent them from getting dementia. They sidestepped the question. I think we have spectacularly failed in our understanding of dementia and in our approach to the treatment of it. And I think when this all gets sorted out, people look back on this era and say, what were those people thinking? Because the data were clear enough to tell them they were on the wrong track. And to imagine that this would all boil down to a single protein abnormality, particularly in the face of this heroic work that Rush has done and other groups have done to really demonstrate the complexity of disease in late life dementia, I think we will look back and wonder what we're thinking about. So my motivation is to say, if we use a disease model for a complex syndrome, we will not get very far. And it also plays into my other great fear about the idea of frailty, which I don't think renaming it as resilience or intrinsic capacity or anything will help us with at all, is that many people who are very disease focused, who become very, very successful and have patients they've saved from death, it means so much to them by being ultra specialists, right? And it's clear if you've got something that needs a very technical procedure done, go to a place that's doing it all the time, not twice a month, right? But those people, when they hear about frailty, they hear of a way to exclude patients from risk or exclude themselves from blame if things do not go well. And we're putting nowhere near the emphasis we should on reducing the risk that the frail old people have. And I can see this happening with cognitive frailty too. Nothing to do for us here, but the family wanted it anyway, so we had to do. But turns out, they've never been the same since. I think we should be very skeptical about the diseaseness, about trying to make these complex syndromes into single diseases. That's my sense of it.
And in fact, maybe we can let Dr. Cano answer in a minute, but I think you probably answered the next question that it said, do we need to roll out Alzheimer's disease before diagnosis of cognitive frailty? If yes, how do we rule out AD? Well, I guess you talk about biomarkers. I don't know if you want to add anything else to that, Dr. Rockwood or Cano?
No.
Okay, that was addressed. Dr. Cano, anything to add?
Yes. I think the key of the concept is the functionality, because if we know the result for the last papers related with the treatment, the treatment with the Alzheimer's disease, the results are not good. And for example, in the Lopera group in Medellin, that had the treatment for 8 years for the family with a mutation, autosomical dominant 14 chromosome, with more than 300 patients with intervention, and the results were not good. And the interpretation for that is maybe the beta amyloid, that is the biomarker that they use it. Maybe it's possible that is a epiphenomenon related with the disease, and also the intervention is better before the accumulation of beta amyloid. And in that family, they have the expression of the disease, because it's autosomical dominant, the penetration is 100%, is near to 40 years. Yes, and in that cases, they can conclude that if they have amyloid in the analysis on the biomarkers, maybe this is a palliative care. They say that, the group say that, and maybe the best intervention is before, maybe 10 or 12 years before the accumulation on the brain. For that, what type of intervention can you have? Maybe genetic intervention. They have a very good proposal to new heterozygous approach to that substance related with the chromosome 19, maybe with the art exercise, maybe with nutrition, maybe before the functional decline. And we don't have the answer now, but we know the way to understand that better. But the reality is that the actual treatment for when you have the Alzheimer's disease, that independent of is mild, moderate, or severe, the results are very, very bad.
All right. Thank you, Dr. Cano. And following up with some of the questions, of course, there's some overlap there, but is there a valid tool to measure cognitive frailty?
Yes, we have the criteria, and we can use the criteria for the frailty diagnosis, that you have many possibilities, and the pre-frail also to diagnosis, but also at the same time you can have the mild cognitive impairment diagnosis. And we do have, when you have the both criteria, in summary, you have the diagnosis for a cognitive frail. And And the key of that also, I can say again, is the functionality, because if you have compromise with your functionality, you have dementia or Alzheimer or other dementia. But if you conserve your functionality, especially in instrumental activities of daily living, that is a mild cognitive impairment. And in that case, you can have the criteria for the diagnosis of the syndrome. Yeah.
And I guess any tool, I'm not aware of any specific tool designed to assess cognition in patients with frailty, but I guess any of the validated tools that we already have, MOCA,
yes. Yes, they proposed the criteria in 2013, the CDR criteria, 0.5, and that is you conserve the use functionality, especially in activities of daily living. Yeah.
Okay, thank you. This question is for Dr. Rockwood. Does the association between frailty index and cognitive impairment and the association between physical frailty and cognitive impairment have different underlying mechanisms?
Yeah, so I think this is a really interesting question. I think that one of the questions I answered in the chat, I cited some papers that looked at the bidirectionality in terms of dementia and frailty. And so there was a really good paper, again, from the Rush group, published with Aaron Buckman in Journal of Gerontology, Biological Sciences, Medical Sciences in 2014, that looks at the bidirectionality issue. And we have done some observational work as well to look at changes in the degree of frailty, or changes in health and changes in cognition. And generally we find that the changes in frailty come first, and they tend to reflect poor overall health, which then gets expressed as poor brain health, which then gets called dementia when it interferes with function. So the mechanisms, I think, is going to be tricky, because I doubt it'll be a single one. And the other thing is that some part of our conceptualization of social circumstances and frailty needs more rigorous sorting out than has typically been done. And one of the things that I think, as we look to better understand what dementia is, we should go back to some of the descriptions from the 60s and 70s, when they're doing they were trying to tell clinicians what to look for in someone who has dementia. And they very much emphasize that they were not indifferent to memory, but they very much emphasize what we would now call executive function. And we know that generally the executive function can become impaired in circumstances of loneliness and extreme deprivation. So these, I think, will be important ways to tackle the question. How we represent that in terms of mechanisms is less clear to me, but I would imagine that one of the ways to do it is to see what things can make this better, and then what does it turn out they are improving. And I would be inclined to pursue those lines of inquiry, because we have some evidence from studies up till now about what that might look like. And I'll pause there, though I'm happy to discuss that more.
Great, thank you. And I think the next question is also interesting, because talks about, I guess, the way I read it, and you can read it too, it's about the issue of social frailty. And I guess this is going to the point of social determinants that are known to be associated with dementia and frailty too. Do we have any outcomes which assess all the determinants, I guess, social determinants of frailty and cognition?
So I think it's very important that we study social determinants carefully. You know, as humans, we're hardwired to share our burden, and very burdened people can be very socially engaged. But it's not clear that they will harvest all of the benefit of the social engagement in the face of a lot of deprivation. So what we need is some set of contracts that will help us to conceive of the problem so that we can better grasp it. the way that our group has looked at it, because we have resisted putting social items in the frailty index, we look at a separate contract called social vulnerability, and we found that for theoretical but also good operational reasons, including analysis, you get better explanations when you get better discrimination, better prognostication when you take that approach. And it also allows us then to not oblige everybody to be socially vulnerable in the same way. And this, I think, winds up being useful. For example, we found that at many income levels, you still find people with some social vulnerability, and that becomes important for them. So I'm not trying to dodge the question. I'm trying to portray, when you look at it carefully, it's more complex. And so I think there's a lot of merit to, as we've done with the Frailty Index, boiling it down to a single construct. So you do the dimensionality reduction at the level of the variable, not at the level of the model. And then you try and take into account where the interactions seem chiefly to be occurring and what is driving them within each index. And that, I think, is a profitable line of inquiry. With our group, I have other colleagues who do that line of work. So I believe the problem to be tractable, but not easy.
Dr. Khan, of course, you most of the data comes from high-income countries, Canada, United States, Europe. Colombia is a middle country, so there are other issues that you are facing on a day-to-day basis. So what's your take on that?
Yes, we have a study with with a partner for US related with the social factors related with cognitive decline, not with frailty, with cognitive decline. And that study, the results were pregnancy before 15 years, the nutrition, malnourished in the especially in infants, in adolescents, and the poor people also, and the opportunities to education. The low education is a real factor related with cognitive. That is important because it's cognitive function, not frailty. In this moment, we have a project is ongoing related with the guerrilla in the FARC guerrilla related with the cognitive problems after the conflict is stopped. And we have an evaluation related with the violence related with the frailty and the cognition, but that is still the studies ongoing and is also very important and also is related with the social approach.
Thank you, Dr. Cano. I guess we have time for one more question. I think I have some interesting issues there, but so what are your thoughts now? ICOPE and intrinsic capacity, as you mentioned during the presentations, and also Dr. Vellas, of course, has done a lot of work for that. What do you think about ICOPE for frailty screening and for cognitive screening?
Dr. Rockwood, if you want to go first.
So I really don't have as much experience with it, and and I probably have got this wrong, but some of the discussions that I've heard around it have been more at an aesthetic level, like it's more pleasant to talk about and such. And again, my fear when I think about the bad things that can happen by concerning yourself with frailty is that it encourages people only to look at the degree of risk and not at ways to mediate that risk or to make that risk better. And it's not clear to me how ICOPE's going to turn out on that.
Dr. Cano?
Yes, I had the experience to know the Professor Vellas study 1 month ago in a PAHO meeting in Chile 1 month ago. And I know the results of that study. The first topic is the ICOPE is an instrument to primary care, yes, and is you have different steps to implement the proposal or the ICOPE tools. And I think it's good idea to have a fast screening in the first step, but I think the evidence for the tools not are the best, but are that we have now. And for that is a good opportunity, and that's the WHO and PAHO topic to have a healthy aging in these 10 years. And I think we are going we are working and starting studies related with that. We need more evidence relating with that tool, but I think it's a good way, especially because it's in primary care, and that is they have the elderly people, they have the opportunity to work with the social workers and the health team related with the possibility to have a screening and also to early intervention. And that, I think, is the most important concept for me, because if you have an early or easy diagnosis and early, you can have the possibility to early intervention, especially in nutrition and in activities, in physical activities.
Great. I think we ran out of time. I appreciate the participation of Drs. Rockwood, Cano, and Vellas by video. Again, thank you for your valuable presentations and question and answers sections. And I would like to remind our participants about our next webinar panel on Wednesday, May 10th. There is going to be an hour change. It's going to start at 5 p.m. Eastern time to accommodate our colleagues in Asia, Australia, and New Zealand, among other countries. Professor Jin Wu from the Chinese University of Hong Kong, China, will deliver the webinar Frailty, the Research Clinical Practice Gap. Again, please complete your evaluations at the end of the webinar. Thank you for joining us, and goodbye. See you next month.